When do we label any patient with the iron deficiency anemia? So basically, when we look at the complete blood count, the HB concentration, hemoglobin concentration, or the red blood cell volume is 2 standard deviation below the mean for that specific age or gender. There are multiple causes of iron deficiency anemia. Here we are going to specifically discuss the causes in children. So we can categorize it in two types that will lead to the iron deficiency anemia. First is blood loss that will lead to the iron deficiency anemia in children. The second is nutritional cause. So the blood loss includes bleeding from the placental vessels, twin-to-twin transfusion syndrome, hookworm infestation, Meckel's diverticulum, peptic ulcer, rectal polyp, and hemorrhagic disease of the newborn. Whereas the nutritional causes of iron deficiency anemia includes when the mother is anemic specifically, and she is breastfeeding her infant or the child, and the other causes repeated pregnancy, preterm, long breastfeeding, excess cow milk intake, poor weaning. Um, that is when an infant or a child, when weaned off, is not given proper nutritious diet, as in no vegetables or fruits or meat. And the other cause is celiac disease, in which there is kind of an allergic reaction to the rye or barley. So, how does a patient with iron deficiency anemia present to us? Mainly, there is pallor. When you look at the palms of that children or any patient with iron deficiency anemia, it is pale, and the conjunctiva as well is pale. The second sign is koilonychia. So what happens is in iron deficiency anemia, there is spooning of nails that is termed as the koilonychia. There is easy fatigability in patients of iron deficiency anemia, and repeated infections, tachycardia, that is increased heart rate. Soft systolic murmur is felt at the apex of such patients. Pica. So what actually is pica? Pica is when an anemic patient tends to eat things that are not normal. For example, someone eating clay or cement or matchstick or even licking the walls. That is termed as pica. It is due to the iron deficiency anemia. And another clinical feature is that if the patient has severe anemia, uh, like when HB is less than 4 or less than 6, it can lead to heart failure. So I hope that's clear so far. Now coming to the investigations. So a patient came to you with these clinical features, and then you just got suspicious that the patient is suffering from iron deficiency anemia. So you ordered some investigations, including the first and the main one to rule out iron deficiency anemia is complete blood count with indices. So what do we see in that? Normally the HB is 12. When the HB is less than that, it is considered as anemia. And with the indices, MCV, MC8C, or MCH, these are all decreased in the patient with iron deficiency anemia. Coming to the peripheral smear, you also order generally peripheral smear with the CBC to check the RBC morphology. So, in the iron deficiency anemia, there is a picture of microcytic hypochromic anemia. So, what happens is cell size is decreased and HB content is decreased. That is normally the HB molecule is red. But in case of this anemia, HB content is decreased, so there is the central pallor. And retic count is normal or slightly elevated. It usually indicates bone marrow function. So the main investigation, the confirmatory investigation among these is serum ferritin. What actually indicates what it actually indicates is that the storage in bone marrow. When serum ferritin is less than 10, so we label it as iron deficiency anemia. Serum iron is another investigation performed to rule out iron deficiency anemia, and when it is less than 30. So if less than 30, it is iron deficiency anemia. And serum ferritin is less than 10. Total iron binding capacity. These are the sites to bind the iron. Alright, that is increased. DIBC is increased in iron deficiency anemia. So it is more than 350. There is this thing that is transferrin saturation that is decreased in such patients. So what happens is there is this HB hemoglobin molecule. It has different sites to bind the iron, so it carries the iron with it. When there are increased sites to bind, it means that there is decreased iron and there are free sites to bind the iron. So decreased iron leads to increased sites to bind. That is decreased uh, transferrin, decreased iron saturation, transferrin saturation, leading to increased total iron binding capacity. And coming to the soluble transferrin receptors, it is also another investigation um, to rule out iron deficiency anemia. So the soluble transferrin receptors are increased. I hope that's clear so far. So the patient came to you with the clinical features of iron deficiency anemia and you ordered some investigations to rule out, and the patient turned out to be iron deficiency anemia. So how are you going to treat that patient? It can be through three routes: oral, parenteral, or transfusion. So you can either prescribe the patient oral iron. Um, That may be tablet ferrous sulfate 200 mg thrice daily or tablet ferrous gluconate 300 mg twice BD. It is usually given with vitamin C drink, that is orange juice or lemon juice, to increase the GI absorption. And the second treatment of the iron deficiency anemia is parenteral iron. It can be iron sucrose, iron dextran, and iron carboxymaltose. And if severe anemic patient or angina, or if hemoglobin is less than 6, or if the patient has developed congestive cardiac failure, you need to transfuse PCV's packed cell volume immediately. And you have to treat the underlying cause in the long run to treat and prevent the recurrence of the iron deficiency anemia. So that's pretty much it.